Cardiac Disease and Pregnancy Part 2. Hypertensive disorders of pregnancy. Examples include chronic hypertension, gestational hypertension, preeclampsia, and preeclampsia with severe features, and eclampsia. Examples of severe features of preeclampsia include proteinuria, thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, cerebral or visual symptoms. Cardiovascular impact and hemodynamic changes. Increased afterload in the setting of uncontrolled blood pressure in pregnancy leads to increased maternal myocardial workload with or without poor myocardial relaxation and poor placental perfusion. Preeclampsia and eclampsia remains part of the spectrum of peripartum cardiomyopathy. Chronic and gestational hypertension may be treated expectantly with pregnancy-safe medical therapy. Preeclampsia and eclampsia requires a more urgent approach that considers timing of delivery, fluid management, seizure prevention, lowering blood pressure, and prevention of end organ damage. Anesthesiology considerations, hemodynamic goals, reduce SVR and MAP, anesthetic plan, neuraxial anesthesia, hemodynamic medication plan, antihypertensives, access, usual large bore peripheral IV, monitoring, consider arterial line if severe hypertension requires continuous IV medication, or if non-invasive measurements are inaccurate. Consider transthoracic echocardiography or point-of-care ultrasound. Postpartum hemorrhage prevention and management. Avoid drugs that increase SPR, such as ergometrin and carbopros. Special considerations. Monitor for thrombocytopenia, liver dysfunction, coagulopathy, and myocardial dysfunction. Recovery, usual care. Valvular heart disease. Stenotic valve disease. Cardiovascular impact and hemodynamic changes of stenotic valve disease. Left-sided valvular obstruction limits the ability to provide adequate cardiac output in the setting of low SVR state of pregnancy. Severe mitral stenosis and aortic stenosis remains high-risk lesions for which pregnancy is contraindicated. Patients with severe left-sided heart obstruction are at risk of poor cardiac output, congestion, heart failure, and arrhythmia. Post-delivery autotransfusion may exacerbate this physiology. Serial echo is often used for assessment. Mitral stenosis. Pathophysiology. Mitral stenosis causes underfilling of the left ventricle and increased pressure and volume upstream of the valve. Pulmonary vascular pressures are initially maintained by left atrial dilation. As the disease progresses, there is increased pulmonary artery pressures, which leads to reactive pulmonary vasoconstriction and pulmonary hypertension. Adaptive RV hypertrophy fails to compensate for volume and pressure overload, leading to progressive RV dilation and failure. Pressure gradient across the narrow mitral orifice increases with the square of cardiac output. Rapid heart rates, especially with atrial fibrillation, reduces diastolic filling time and leads to reduced cardiac output. Chronic left atrial dilation increases the risk of AF. Intracardiac thrombus, either in the left atrium or left atrial appendage, may develop due to low velocity blood flow. If present, anticoagulation is required. Critical MS is a fixed low cardiac output state. Presentation. Symptoms include dyspnea, hemoptysis, bronchitis, fatigue and palpitations. Signs include mitral phasis, peripheral cyanosis, signs of right heart failure, tapping apex beat, loud first heart sound, opening snap, low-pitch diastolic murmur heard best at the apex. ECG may show P mitrale if sinus rhythm or AF. Chest X-ray may show valve calcification, large left atrium, double shadow behind the heart on PA film, splaying of carina, and curly B lines. Echocardiogram can delineate valve area. Normal mitral valve area is 4 to 6 cm square, symptom-free until 1.6 to 2.5 cm square, moderate stenosis 1 to 1.5 cm square, severe mitral stenosis less than 1 cm square. Echo can measure the gradient, RV function, and detect intracardiac thrombus. Patients with MS who meet standard criteria should undergo valvular intervention prior to elective surgery, such as open or percutaneous mitral commissurotomy. Regarding aortic stenosis, refer to Finals SAQ 16, Aortic stenosis. Anesthesiology considerations, hemodynamic goals. Keep the circulation slow, full and tight. Balance myocardial oxygen supply and demand. Maintain afterload. Avoid tachycardia. Aim low to normal heart rate. Aim for normal sinus rhythm. Arrhythmias must be treated promptly or hemodynamic collapse may ensue. Consider defibrillation when indicated. Adequate preload. Avoid fluid overload, which may lead to pulmonary edema. Maintain aortic diastolic blood pressure at baseline. Maintain SVR. Avoid hypotension. Avoid sudden changes in afterload. Avoid hypercapnia, acidosis, hypothermia, hypoxia, etc., which may exacerbate pulmonary hypertension. Maintain cardiac contractility. Inotropes as indicated. Anesthetic plan. Carefully titrated neuraxial anesthesia. GA or slow onset CNB have been advocated for caesarean section. The technique is probably less important than the skill with which it is applied. Effective analgesia is important to avoid catecholamine-induced tachycardia and hypertension. Hemodynamic medication plan, vasopressor medications as indicated. Patients with severe AS or MS have fixed cardiac output and cannot compensate for decreased SVR, leading to hypotension. This may lead to myocardial ischemia. Access usual large bore IV. Insertion of central line enables administration of vasoconstrictors. Monitoring. Consider outline for severe stenotic lesions placed prior to induction. Consider transthoracic echo or point-of-care cardiac ultrasound. PPH, usual care. Recovery, consider intensive care unit for high-risk patients. Regurgitant valve disease. Cardiovascular impact. Regurgitant valve disease is typically better tolerated than stenosis, but chamber dilation may occur. Aortic regurgitation, pathophysiology. AR results from diseases involving aortic leaflets themselves, or aortic root or annulus. Causes of AR affecting aortic leaflet, degenerative disease, i.e. rheumatic heart disease, connective tissue disease, and bicuspid valve. Causes affecting aortic root or annulus, Marfan syndrome, connective tissue disease, and aortic dissection. Acute AR. For example, due to endocarditis or acute type A aortic dissection, large regurgitant volume leads to LV overload. LV diastolic pressure increases, approaching aortic diastolic pressure. Untreated, MR follows, leading to pulmonary edema and cardiogenic shock. Treatment is emergency valve surgery. Chronic AR, return of blood back to the ventricle during diastole, contributes to preload. Increased LV-EDV produces compensatory increased force of contraction and stroke volume. Aortic systolic pressure rises, but aortic diastolic pressure is reduced due to regurgitation. Eccentric LVH followed by LV dilation prevents significant increase in LV filling pressures despite large regurgitant volume. Progressive LV dilation increases wall stress. Decompensation can be caused by further increased LV wall stress, leading to reduced diastolic compliance and LV systolic function. Presentation. Symptoms includes palpitations or angina due to reduced coronary perfusion in the setting of increased LV wall stress. Symptoms of heart failure in decompensated AR. Signs includes collapsing pulse, white pulse pressure, visible neck pulsation, Corrigan sign, head nodding, Demasset sign, visible capillary pulsations in the nail beds, Quincke sign, diastolic murmur at the second intercostal space, right sternal edge. Chest X-ray may show cardiomegaly and boot-shaped heart. ECG, non-specific LVH. Echo provides quantitative analysis of aortic leaflets and aortic root. Doppler studies allow estimation of regurgitant severity. LV size and function can be assessed. Patients with poor functional capacity should be considered for valve replacement prior to elective surgery. Mitral regurgitation, pathophysiology. MR are better tolerated than stenotic lesions. Asymptomatic patients with normal LVEF have a favorable prognosis. MR results from leaflet, caudal, or papillary muscle abnormalities, or as a consequence of LV dysfunction, functional MR. Causes affecting leaflets, complication of endocarditis, rheumatic heart disease, or mitral valve prolapse, myxomatous degeneration. Causes affecting chordae, chordae rupture after acute myocardial infarction or after bacterial endocarditis, causes affecting papillary muscles, ischemic posterior papillary muscle dysfunction. LV failure leads to dilation of mitral valve annulus. Left atrium is subjected to volume and pressure overload. Adaptive dilation occurs gradually. As much as 50% of LV volume flows into the dilated left atrium before aortic valve opens. Increased LVEF occurs and over time LV dysfunction may occur. Degree of regurgitation is determined by afterload, size of regurgitant orifice, and heart rate. Moderately increased heart rate decreases the time for regurgitation in systole and decreases the time for diastolic filling, reducing LV overload. Chronic MR will lead to pulmonary vascular congestion, followed by pulmonary hypertension and right heart failure. Presentation: fatigue, dyspnea, palpitations, and symptoms of right heart failure, pulmonary edema, displaced and forceful apex due to LVH, soft S1, apical pansystolic murmur radiating to axilla, and loud S3. ECG may show left atrial enlargement or AF. Chest X-ray may show left atrial and LV enlargement and mitral annular calcification. Echo gives quantitative estimate of regurgitant fraction. It includes measuring the vena contractae, narrowest cross-sectional area of a fluid jet, which corresponds to the regurgitant orifice area and MR severity. Assess ventricular function. TOE is particularly useful as the left atrium is adjacent to the esophagus. Perioperative risk. MR increases cardiac risk during non-cardiac surgery, especially if LV function is reduced. In asymptomatic patients with severe MR, elective intermediate risk non-cardiac surgery is reasonable with appropriate perioperative hemodynamic monitoring. Patients with poor functional capacity should be considered for valve repair or replacement surgery prior to elective surgery. Anesthesiology considerations. Hemodynamic goals. Keep the circulation full, fast, and forward. Aim for high to normal heart rate, about 90 beats per minute. Faster heart rate reduces diastolic regurgitation time. Persistent bradycardia may need to be treated with beta agonists or anticholinergics. Ensure adequate preload. Low SVR, which decreases afterload while maintaining coronary perfusion pressure. Maintain sinus rhythm. Treat arrhythmias promptly. Consider defibrillation when indicated. Maintain cardiac contractility. Avoid hypertension. Avoid bradycardia. In advanced disease, pulmonary hypertension is common. Avoid factors that increases pulmonary hypertension. All these goals aim to promote forward systemic flow. Anesthetic plan. Neuraxial anesthesia unless contraindicated. Hemodynamic medication plan. Consider vasopressors with chronotropic properties and inotropes. Access, usual large bore IV. Monitoring, usual care. IABP is useful for high-risk patients. Consider transthoracic echo or point-of-care cardiac ultrasound. PA catheter or TOE, if available, may be useful to guide intravascular volume management. PPH and recovery, usual care. Cardiomyopathy with severe LV systolic dysfunction. Cardiovascular disease. Peripartum cardiomyopathy. This is a dilated cardiomyopathy that occurs between the last month of pregnancy and 5 months postpartum. Diagnosis is based on echocardiography and is a diagnosis of exclusion. Incidence has marked geographic variation, ranging from 1 in 100 in parts of Nigeria to 1 in 4,000 in the US. Estimated mortality 7 to 50%. Treatment is multidisciplinary with expectation of severe LV dysfunction. Bromocriptine may be used to stop lactation and enhance LV recovery, but this is controversial. The cardiomyopathy can recur, and if cardiomyopathy did not completely resolve, the mortality in subsequent pregnancy is very high. Preconceptual counseling is crucial. Increased risk conditions include systemic right ventricle and any systemic ventricular systolic dysfunction. High-risk conditions include systemic ventricular EF less than 30% and those with NYHA class 3 to 4. Cardiovascular impact and hemodynamic changes. Patients with severe systolic dysfunction or elevated NYHA class are at highest risk for low cardiac output and cardiogenic shock, and pregnancy is generally contraindicated. In those with prior peripartum cardiomyopathy, there is high risk for worsening LV dysfunction and 19% risk of death if the recovered LVEF is less than 50%. Young patients with cardiomyopathy may appear clinically well until late in pregnancy due to robust compensatory mechanisms. Medical heart failure therapies may include beta blockers and afterload reduction. Anesthesiology considerations, hemodynamic goals: maintain normal sinus rhythm, augment contractility to maintain cardiac output. Anesthetic plan, aim for carefully titrated neuraxial anesthesia. Hemodynamic medication plan, inotropes. Access, usual large bore IV, consider central line. Monitoring, consider IABP, transthoracic echo, and point of care cardiac ultrasound. PPH, usual care. Special considerations, inotropes, mechanical circulatory support or ECMO, may be considered in low cardiac output, severe right heart dysfunction, systemic RV, and cardiogenic shock. Recovery, consider ICU care. Ischemic heart disease. Cardiovascular disease leading to MI includes coronary artery disease and spontaneous coronary artery dissection, SCAD. MI during pregnancy carries 20% mortality. Infarction most commonly occurs in the third trimester. If possible, delivery should be delayed at least 3 weeks after myocardial infarction. Both elective caesarean section and vaginal delivery have been advocated. In either case, cardiac stress should be minimized with effective analgesia. CVS impact and hemodynamic changes. Coronary artery disease. Patients with underlying atherosclerotic coronary artery disease are at increased risk of MI associated with the physiological changes in pregnancy. Depending on the degree of ischemia present, cardiac arrest, ACS, arrhythmia, or heart failure may result, and these should be monitored for throughout pregnancy and postpartum. Preeclampsia and reduced birth weight have been shown to be more common in patients with atherosclerosis or diabetes. Neonatal events were also more frequent in patients with coronary artery disease. SCAD occurs in patients without atherosclerotic coronary disease and remains the most common cause of ACS in pregnant patients. SCAD was most common 18 weeks after conception in a large case control study. Potential risk factors for SCAD includes hypertension and vascular diseases such as fibromuscular dysplasia or connective tissue disease. It is important to recognize that patients with SCAD, like those with atherosclerotic disease, are at risk for heart failure, arrhythmia, and cardiac arrest. However, most patients with SCAD tolerate the remainder of pregnancy and lactation. Risk for recurrent SCAD has been shown to be higher in subsequent pregnancies for patients with SCAD. Anesthesiology considerations. Hemodynamic goals: maintain normal sinus rhythm, aortic diastolic blood pressure, and cardiac output. Anesthetic plan: aim for carefully titrated neuraxial anesthesia. Hemodynamic medication plan: vasopressors, inotropes, and nitroglycerin as indicated. Access: usual large bore IV, consider CVL if low cardiac output. Monitoring: consider IABP, consider transthoracic echocardiography or point of care cardiac ultrasound. PPH management: avoid methyl ergonovin or ergometrin. Special considerations: consider performing caesarean delivery in cardiothoracic operating room in high-risk patients. In patients with low cardiac output, severe right heart failure, and cardiogenic shock, consider use of mechanical circulatory support or ECMO. Recovery: consider intensive care unit. Pulmonary hypertension. Definition: normal mean pulmonary artery pressure (MPAP) is 14 mmHg. Pulmonary hypertension is defined as MPAP 25 mmHg or more, measured at right heart catheterization at rest. With mild pH having MPAP of 25 to 40, moderate pH MPAP of 41 to 55, and severe pH MPAP of more than 55 mmHg. Pulmonary artery systolic pressure (PASP) is estimated from peak tricuspid regurgitation velocity via TOE, mild pH PASP of 35 to 45, moderate pH PASP of 46 to 59, severe pH PASP of more than 60 mmHg. Classification of severity of pH is based on MPAP and PASP as mentioned, or NIHA class. Class 1, pH with no symptoms or limitation to ordinary physical activity. Class 2, pH with mild symptoms and slight limitation during ordinary activity. Class 3, pH with marked limitation of physical activity, but is comfortable at rest. Class 4, pH with signs of right heart failure, possibly even at rest. There is inability to carry out any physical activity without symptoms. Causes of pH. pH can be classified into 5 groups with similar pathophysiological mechanisms, clinical presentation, and hemodynamic characteristics. Class 1, pulmonary artery hypertension. Class 2, pH due to left heart disease. Class 3, pH due to lung disease and/or hypoxia. Class 4, pH due to pulmonary artery obstruction. And Class 5, pH with unclear mechanism. Examples of Class 1, idiopathic PAH, drug or toxin induced associated with congenital heart disease, portal hypertension, HIV, or persistent pulmonary artery hypertension of the newborn. Examples of Class 2, pulmonary hypertension due to heart failure, valvular disease or congenital cardiomyopathies. Examples of Class 3, obstructive, restrictive or mixed lung disease, hypoxia, without lung disease and developmental lung disorders. Examples of Class 4, chronic thromboembolic pulmonary hypertension and other PA obstructions. Examples of Class 5, hematological disorders, systemic and metabolic disorders, and complex congenital heart disease. pH due to left heart disease is overwhelmingly the most common cause of PH, constituting 75% of all causes of PH in population studies. Examples include mitral valve disease, long-standing LV systolic or diastolic dysfunction, and aortic valve disease. Increased left atrial pressure is transmitted retrogradely to the pulmonary veins, capillaries, and finally pulmonary arteries, leading to PH. The right ventricle has limited capacity to compensate for raised PAP or acute increase in afterload, leading to increased risk of RV failure. RV dilation occurs as the RV fails, and via interventricular dependence, the interventricular septum shifts towards the left ventricle, leading to reduced left ventricle preload, reduced cardiac output, and shock. Increased RV systolic pressure leads to reduced gradient for the RV coronary perfusion, leading to increased risk of RV subendocardial ischemia and further dilation. Cardiovascular impact. In patients with WHO Group 1 PAH not on medical therapy, mortality is high, more than 50%. However, with newer directed medical therapy, it is likely to be in the low double digits. Increased maternal morbidity and mortality occurs most commonly as a result of RV failure and shock precipitated by shifts in RV preload, inability to adequately lower PVR to increase cardiac output, and changes in RV preload caused by blood loss and autotransfusion during delivery. Presentation. Symptoms are non-specific. There may be signs of heart failure such as dyspnea, fatigue, angina and syncope, hemoptysis and hoarse voice due to rupture or distension of vessels in the pulmonary vascular bed. Other symptoms related to the causative disease process may be present. Examination for signs of right heart failure, pansystolic murmur indicating tricuspid regurgitation, and a diastolic murmur indicating pulmonary regurgitation. Diagnosis of PH may be via right heart catheterization. This is the gold standard for diagnosis as MPAP can be measured directly. Transesophageal echocardiography is the primary investigation due to its availability. PASP is estimated from peak tricuspid regurgitation velocity. PASP of 35 to 45 indicates mild PH, 46 to 59 indicates moderate PH, and more than 60 mmHg indicates severe PH. Right atrial pressure can be used to stratify pulmonary hypertension. ECG may show normal findings, or P. pulmonary, right axis deviation, RV hypertrophy, right bundle branch block, RV strain, and prolonged QTC. Investigations to diagnose etiology of PH includes chest X-ray, which may show COPD or sarcoidosis, echo, CTPA or VQ scan to diagnose PE, sleep studies to diagnose OSA, liver ultrasound to diagnose portopulmonary hypertension, and cardiac MRI to diagnose cardiomyopathy or congenital heart disease. Tests for prognostication includes 6-minute walk test and CPET. This table shows some determinants used to estimate 1-year mortality based on expert opinion. Patients with high risk have clinical signs present, progressive symptoms which are rapid, WHO functional class 4, 6-minute walk test of less than 165 meters, CPET, peak VO2 of less than 35% predicted, VE to VCO2 ratio of more than 45, biochemical markers, BNP, more than 300 ng per liter, NT-proBNP, more than 1400 ng per liter, imaging, right atrial area more than 26 cm square, and pericardial effusion present. Risk factors associated with increased perioperative mortality and morbidity includes NYHA class 2 or more, 6-minute walk test less than 300 meters, PVR more than 400 dyne per second per cm -5, elevated RAP more than 14 mmHg, low cardiac index in right heart catheterization less than 2.4 liters per meter square, history of CAD, PE, CKD, and RV hypertrophy with severe systolic dysfunction, emergency surgery, high-risk surgery, duration of surgery more than 3 hours, and intraoperative vasopressor requirement. Treatment options for PH. Non-specific treatment includes anticoagulation for idiopathic PAH only, diuretics for decompensated right heart failure, and oxygen therapy which reduces PVR. There is no evidence for long-term oxygen therapy. Calcium channel blockers, less than 10% of patients benefit. Diltiazem and nifedipine are category C in pregnancy. Synthetic prostacyclin analogs such as epoprostenol, category B, have shown to improve survival in idiopathic PAH. Treprostinil, category B, and inhaled iloprost, category C, have shown to improve symptoms and reduce clinical events. Endothelin receptor antagonists such as macitentan, ambrisentan, and bosentan are category X and are contraindicated in pregnancy. PDE5 inhibitors such as sildenafil and tadalafil are category B and improve exercise capacity and symptoms. Guanylate cyclase stimulants such as riociguat is category X and is contraindicated in pregnancy. Heart lung and double lung transplantation improves survival in idiopathic PAH. This table summarizes the different drug classes used to treat PH. Calcium channel blockers such as amlodipine, felodipine, nifedipine, and diltiazem, FDA pregnancy category C. PDE5 inhibitors such as sildenafil and tadalafil, FDA pregnancy category class B. Endothelin receptor antagonists such as ambrisentan, bosentan, and macitentan, FDA pregnancy category X. Prostacyclins such as iloprost, epoprostenol, and treprostinil, pregnancy category class B to C. Prostacyclin analogs such as selexipag, FDA pregnancy category not assigned. Guanylyl cyclase stimulator riociguat, FDA pregnancy category class X. This table shows FDA categories in pregnancy, category A, B, C, D, and X, and is included here for completion. Anesthesiology considerations. Anesthetic plan, aim for carefully titrated neuraxial anesthesia. Hemodynamic goals. Avoid factors that increase PVR to avoid increased RV afterload and avoid RV failure. Examples of factors affecting PVR includes physical, metabolic, autonomic, and local factors. Physical factors that increase PVR includes reduced PAP, reduced PVP, increased alveolar pressures, increased lung volumes beyond FRC, and reduced lung volumes beyond FRC. Metabolic factors increasing PVR includes hypoxia, hypercapnia, acidosis, and hypothermia. Autonomic factors increasing PVR includes alpha-1 agonism, lack of beta-2 agonism, and lack of parasympathetic activation. Local factors includes lack of dilators such as nitric oxide, iloprost, milrinone, or GTN, and presence of vasoconstrictors such as endothelin, thromboxane A2, serotonin, histamine, and bradykinin. Aim to maintain RV and pulmonary circulation coupling and prevent pulmonary hypertension crisis with pulmonary vasodilators and inotropes. Improve RV inotropy with low-dose adrenaline or inodilators such as dobutamine or milrinone as indicated. Maintain SPP at baseline or minimum SPP of 90 mmHg and 40 mmHg above systolic PAP. Use low-dose vasoconstrictor to maintain systolic BP if indicated. Aim for MAP 65 mmHg or more and 20 mmHg above MPAP. RV coronary perfusion pressure is maintained by maintaining SVR and MAP, thereby optimizing aortic diastolic pressure. During central neuraxial blockade, use carefully titrated anesthesia to minimize rapid block of sympathetic fibers. Tachycardia and increased pulmonary afterload causes reflex increased RV contractility via thoracic sympathetic fibers, and blocking thoracic sympathetic fibers could lead to critical reduction in cardiac output and heart failure. Lower RAP to maintain MAP of more than 65 mmHg. Maintain sinus rhythm and AV synchrony. AV tachyarrhythmias can lead to right heart failure and death. For rhythm control, consider amiodarone as the drug of choice. Use digoxin if rhythm control is not possible. Beta blockers are poorly tolerated. Maintain preload. Patients are preload dependent but tolerate overload poorly. Consider CVP or TOE monitoring to assess preload. Blood loss should be replaced promptly. Prepare for events during surgery which may affect preload, afterload, or pulmonary flow, such as cementing during orthopedic surgery, microemboli after tourniquet release, pneumoperitoneum during laparoscopic surgery, cross-clamping of major blood vessels, and change in patient position. Avoid fluid overload. Fluid therapy should be targeted and restrictive. Effects of anesthetic drugs in pulmonary hypertension. Isoflurane, desflurane, and sevoflurane leads to dose-dependent decrease in RV contractility. Isoflurane and desflurane increases PVR. Sevoflurane does not increase PVR. Nitrous oxide increases PVR. Propofol reduces RV contractility and reduces SVR. Thiopental reduces RV contractility and SVR. Ketamine increases PVR. Noradrenaline and vasopressin improves perfusion of right coronary artery, reduces PVR to SVR ratio, increases RV contractility, and marginally improves cardiac output. Adrenaline, dobutamine, and levosimendan increases RV contractility. Milrinone, an inodilator and PDE3 inhibitor, reduces PVR to SVR ratio. However, reduced SVR can compromise coronary artery blood flow. Sildenafil reduces PVR and can be given oral or IV. Inhaled pulmonary vasodilators reduces PVR. Access usual large bore peripheral IV line. Consider CVL and pulmonary artery catheter. Monitoring, consider IABP, intraoperative TOE or PA catheter. PPH management, avoid methyl ergonovin, ergometrin, and carboprost. Special considerations, for high-risk patient, consider performing C-section in cardiothoracic operating room. Consider ECMO or mechanical circulatory support in severe PH, Eisenmenger, low cardiac output, severe right-sided heart dysfunction, systemic RV, and cardiogenic shock requiring inotropes. Recovery, consider ICU care. Common causes of post-op death includes RV failure, arrhythmias, sepsis, PE, respi failure, and myocardial infarction. Congenital heart disease. Cardiovascular diseases. Increased risk conditions includes morphological right ventricle in systemic position with good or mildly decreased ventricular function, Fontan circulation uncomplicated, unrepaired cyanotic heart disease, other complex congenital heart disease such as ASD, repaired coarctation without residua, and moderate aortic dilation in Marfan's, bicuspid, AV, TOF or Turner's. These conditions indicate WHO risk class 3 lesions, which has been discussed in the previous videos. These patients should be cared for at appropriate level hospital with appropriate members of pregnancy heart team available. High-risk conditions indicating WHO risk class 4 lesions includes congenital heart disease with pulmonary hypertension, Fontan circulation with any complication, systemic RV with moderate to severely decreased LV function, Eisenmenger syndrome with right to left heart shunt, native severe aortic coarctation, and severe aortic dilation. Other high-risk conditions include severe ventricular outflow obstruction, cardiomyopathy, severe hypoxemia or polycythemia, severe or worsening CCF or evidence of myocardial ischemia, and presence of markers of hemodynamic insufficiency such as syncope arrhythmias or recent stroke. MWHO class 1 and class 2 or 3 are included here for completion. Commonest congenital heart lesions includes ASD, VSD, PDA, TOF, AS, coarctation of aorta, and transposition of great arteries. Cardiovascular impact and hemodynamic changes. The risk of pregnancy in CHD is determined by the original congenital heart lesion and intervention or surgical history. The CVS risk can be affected by development of subsequent acquired cardiovascular diseases such as heart failure or arrhythmia. In uncorrected disease, patients with unrepaired cyanotic CHD or Fontan circulation are at increased risk of maternal CVS events, specifically heart failure and arrhythmia, in addition to obstetric events such as PPH. Large left-to-right shunts will cause RV overload, progressive pulmonary hypertension, and eventual shunt reversal, or Eisenmenger syndrome. Once irreversible pulmonary hypertension has developed, surgical correction is not possible. Patients with CHD-associated PH or Eisenmengers have extremely high mortality, up to 40%. In corrected disease, the patient may have spontaneous resolution or had a corrective procedure. Corrective procedures aims to completely repair the lesion and aim for no long-term sequelae. However, in some cases, a residual defect may be present. For example, pulmonary regurgitation after TOF repair, requiring repeat interventions and may lead to reduced life expectancy. Best assessment of CVS function is generally via exercise tolerance. Few type of CHD involves a morphologically RV placed in the systemic ventricular position, such as DTGA after atrial switch and CCTGA. In the assessment of these patients, exclude surgical sequelae and continuing disease, exclude associated congenital abnormalities, and signs of heart failure. In palliated disease, the patient may have operations that improve functional capacity and life expectancy, but do not restore normal anatomy. Examples include sanding and mustard for transposition of great arteries, Fontan pathway for single ventricle lesions, such as hypoplastic left heart syndrome and pulmonary atresia. These patients may have abnormal circulations and physiology, but avoid the consequences of untreated CHD. Many survive to adulthood, but life expectancy is not normal. Management is best provided in specialist cardiac centers. In the Fontan circulation, also known as total cavo-pulmonary connection, blood leaves a single ventricle and passes through the systemic circulation, then through the pulmonary circulation before returning to the heart. Systemic venous pressure is high, providing a pulmonary gradient across the pulmonary vascular bed. Any pulmonary hypertension is poorly tolerated and results in reduced ventricular filling. Fontan circulation leads to high venous pressures, liver congestion, protein-losing enteropathy, pleural and pericardial effusions. High venous pressures can result in life-threatening hemorrhage from mucosal procedures such as adenoidectomy or nasal intubation. Anesthesiology considerations, perioperative assessment, aim to understand the patient's anatomy and physiology with a view to risk stratification and perioperative planning. History, define severity of lesion in terms of impact on normal activities. Consider relevant comorbidities, check current medications, and obtain a recent cardiology review. Examine for signs of heart failure, cyanosis, and infection. Consider neurological examination for cyanotic patients. Investigations, chest X-ray, ECG, echocardiography, cardiac catheter data, baseline SpO2, lab tests based on proposed surgery. Consider whether surgery should proceed in view of risk versus potential benefit, if the patient can or should be moved to a cardiac center, and if post-op ICU or HDU will be required. Anticipate the likely impact of anesthetic interventions on PVR, myocardial function, SVR, and venous return. Hemodynamic goals. In isomangus, avoid increased PVR. In right to left shunts, cardiac output can be augmented by further increasing the right to left blood flow. As a result, physiology that results in lowering SVR may present initially as worsening hypoxia that does not correct with peripheral oxygen administration. Hence, patients with right to left shunts will not tolerate reductions in SVR. There is also risk of paradoxical emboli, hence avoid introducing air into the circulation. Anesthetic plan, aim for carefully titrated neuraxial anesthesia and maintain SVR. Hemodynamic medication plan, use vasopressors to maintain afterload and SVR. Access usual large bore IV and consider CVL in severe disease. Monitoring, consider IABP, transthoracic echocardiography, and point-of-care cardiac ultrasound on top of standard monitoring. PPH management, usual care, and avoid drugs that increase PVR. Special considerations. For high-risk patients, consider performing caesarean section in cardiothoracic operating room. ECMO and mechanical circulatory support may be considered in severe PH, isomangus, low cardiac output, systemic RV, severe right-sided heart dysfunction, and cardiogenic shock. Cyanosis results from shunting of blood from the right to the left side of the heart through a focal defect or complete intracardiac mixing. Adaptations to chronic hypoxemia includes polycythemia and increased blood volume. Increased blood viscosity impairs tissue perfusion and increases the risk of thrombosis. Coagulopathy due to platelet dysfunction and fibrinogen deficiency may occur. Increased tissue vascularity may worsen bleeding. Air emboli. Any intracardiac shunt, especially right to left shunt, poses risk of air embolism, which may lead to coronary or cerebral circulation obstruction. Meticulous bubble precautions should be taken. Recovery, consider ICU care. Aortopathy. Cardiovascular disease. Increased risk conditions includes Marfan syndrome with aorta 45 to 50 mm, bicuspid aortic valve with aorta 45 to 50 mm. High-risk conditions includes Marfan syndrome with aorta more than 45 mm and bicuspid aortic valve with aorta more than 50 mm. Elevated risk conditions with poorly defined magnitude of risk includes Loeys-Dietz syndrome, vascular Ehlers-Danlos syndrome, which leads to increased risk of aortic dissection, and genetic negative HTAAD-S. Symptomatic Marfan syndrome have high risk of aortic dissection. If the aortic root is dilated, they are usually maintained with beta blockers. Unexplained severe chest pain is an indication for echo and chest X-ray. CVS impact. Hemodynamic and hormonal changes of pregnancy affect the integrity of arterial vasculature, and these are important risk factors for aortic dissection, especially in patients with connective tissue disorders. Patients with vascular connective tissue disease are often at risk of obstetric and neonatal events. For some types of aortopathy, prophylactic aortic root replacement is advised to avoid spontaneous dissection. However, the impact during pregnancy is less clear, but likely includes consideration of absolute diameter and cross-section to height ratio. Pharmacological therapy with beta blockers is often used both in pregnant and non-pregnant states. Anesthesiology considerations, hemodynamic goals, avoid increased shear stress within the aorta and increased SPR, aim for carefully titrated neuraxial anesthesia, hemodynamic medication plan, use of vasodilators as indicated. Access, use large bore IV, consider CVL. Monitoring, consider IABP, transthoracic echo and point-of-care cardiac ultrasound. PPH management and prevention, avoid methyl ergonovine and ergometrin. Special considerations, consider performing caesarean section in cardiothoracic operating room in high-risk patients. Specialized monitoring at the time of labor and delivery is often required and includes close watch over blood pressure and heart rate, with a low threshold for 3D imaging if there is chest pain or signs of aortic dissection. Recovery care, consider ICU. These are my references. Thank you.